as well as Albert Einstein in Philadelphia, and come by way of Damascus, Syria.
Yes.
Um, Today, he's going to talk about, you see up there, non-alcoholic liver disease. And welcome.
All right. Well,
Oh, by the way, he has no financial disclosures.
Isn't he supposed to say that?
well, thank you, Greg, for
Is it
the
you
kind
to say that?
introduction.
Yeah,
I'm
so-
glad to be here today. I guess this is the last lecture of the season, so I'd better make it good for you guys. But I'm here to tell you about a very common disease that everyone in transplant should be aware of. So even if you're not in liver transplantation and you deal with kidney transplant or heart transplant, this is something that you will be dealing with almost on a daily basis. So we'll talk about non-alcoholic fatty liver disease and liver transplantation. So this is an overview for my talk. I'll discuss initially the natural history and the diagnosis of fatty liver disease. Then I'm going to describe for you 4 challenges that we face in liver transplantation related to this disease. The first one is that this disease, NAFLD, is becoming the most common indication for listing and for doing liver transplantation. Second challenge is that now we are seeing more cases of NAFLD progressing to cirrhosis in young patients and they end up needing liver transplant. We're seeing more cases of non-cirrhotic liver cancer develop in these patients, and many of them will need liver transplant. And then after liver transplant, we are seeing disease recurrence that can lead to many complications. And then finally, I'm going to conclude by telling you a little bit about the current management of fatty liver disease, but also some of the new drugs that should be approved in 2019, we think. So when we say non-alcoholic fatty liver disease, it's considered the liver manifestation of the obesity epidemic, insulin resistance, type 2 diabetes. And some people consider NAFLD as a component of the metabolic syndrome, which includes insulin resistance, dyslipidemia, and high blood pressure. When we say fatty liver disease, sometimes patients, they get confused. They think it's all one disease, but fatty liver disease is really a spectrum of diseases, and you should be aware of this because not all fatty liver disease is created equal. So you start by what we call non-alcoholic fatty liver. We used to call it simple steatosis. Here you see just fat accumulating within the hepatocytes, within the liver cells. But there is usually no inflammation, no hepatocyte injury, and no liver fibrosis. So it's just fat accumulating in the liver. And this is probably the most common form of fatty liver disease, and typically it's not progressive, so the majority of these patients will not develop liver cirrhosis. However, about 20-30% of patients with NAFLD will have the aggressive form, what we call non-alcoholic steatohepatitis, or NASH. Here you have fat accumulating within the hepatocytes, but you also have neutrophilic infiltration, hepatocyte ballooning, these are swollen hepatocytes, and then you develop variable degrees of fibrosis. So this is what we worry about as hepatologists, is who has NASH, who has liver fibrosis, because these patients can progress in 10 to 20% to what we call NASH cirrhosis, where you have a lot of fibrosis tissue, scar tissue, and you can start developing complications from portal hypertension. Once you have NASH cirrhosis, you're also at risk of hepatocellular carcinoma, and these 2 categories may need liver transplantation. So for portal hypertension complications or for liver cancer. So this is very important to understand because sometimes we have people coming to us terrified. They hear about fatty liver disease. They think they're going to develop cirrhosis for sure. And the majority of people with fatty liver disease will not end up with cirrhosis. Unfortunately, in liver transplant clinic, this is all we see all day long is NASH cirrhosis. So today, screening for this disease for NAFLD is not indicated even in high-risk populations like severely obese individuals or people with type 2 diabetes. And this is according to the ASLD guideline. This is the Liver and Hepatology Society in America. So what happens if we don't screen for non-alcoholic fatty liver disease? People show up with portal hypertension as the first presentation of their disease. So this is a study that we conducted back at the Cleveland Clinic. We looked at patients coming to us to be evaluated for liver transplantation for the indication of NASH cirrhosis. And we asked a very simple question. How many of these people knew that they had any liver disease before they presented with portal hypertension complications? We included 124 consecutive patients that came to us. 60% had diabetes, majority were obese. But the interesting finding was that 2/3 of people showing up with portal hypertension for liver transplant had no idea that they had any liver disease prior to presenting with decompensated liver disease. So this is very common. I used to have these conversations a lot. People show up, you're talking about liver transplant, they look at you like, I don't drink alcohol, why do I have cirrhosis? And you have to tell them this is from type 2 diabetes and obesity, dyslipidemia. This is how these patients presented. So about 50% presented with new onset ascites. So again, imagine the scenario, you have no idea you have liver disease, next thing you have ascites in your abdomen. And then 15% presented with bleeding varices, 20% with encephalopathy, and then other presentations in about 15%. The issue with the ASLD not recommending screening is also related to the screening methods we have today. So we use typically ALT, liver enzymes, and ultrasound to look for fatty liver disease, but ALT can be completely normal in some people, and they can progress and have NASH and cirrhosis. And ultrasound is very subjective. So what you see here is a normal liver ultrasound. So typically you look at the echogenicity of the liver compared to the kidney. So this is normal, so they're kind of similar. You look at the vessels inside the liver, you can see them clearly. Here, this is fatty liver. So you can see the liver becomes more bright, so more echogenic than the kidney, and then the vessels become blurry. So this is how the radiologists tell you have fatty liver or not. And you can see how this can be subjective, especially when you don't have a lot of fat in the liver. So ultrasound becomes sensitive enough when you have 20, 30% fat in the hepatocytes. But we consider pathologic accumulation anything more than 5% on the liver biopsy. So you would be missing some patients with less steatosis. But more importantly, ultrasound cannot tell you the stage of the disease. It cannot tell you how much fibrosis you have, and it cannot tell you if you have the aggressive disease of NASH or not. So we need new methods. So this is a new machine I want to spend some time on. It's called FibroScan. We have these available at the Texas Liver Institute and available to you guys. We have a portable machine that I carry around San Antonio to show people. And this is really a cool machine. So it measures two things. It measures liver fibrosis, scar tissue, and steatosis. So it looks like an ultrasound. This is the probe. You put this part between the ribs, and then this black part will send a wave through the liver tissue, and you just follow the wave and see how fast it's progressing through the liver tissue. The faster the wave, the more stiffness in the liver you have, the more fibrosis, which tells you that you have advanced disease. This technology was developed in France a long time ago to measure the stiffness of cheese initially, because they like the wine and cheese. And then someone transferred the technology to looking at the stiffness of the liver. So more recently, they added a software called controlled attenuation parameter. So this looks at the attenuation of the wave as it's going through the liver tissue. And the more attenuation you have, the more steatosis you have. And they actually give you a number that tells you how much fat, okay? So these are the images you get with this technology. You don't have to be a radiologist to do this. You just really get numbers with it. So the first number in blue is the steatosis number. The second number in orange is the fibrosis number. So if this one is less than 220, then you don't have steatosis. If this one is less than 6 or 7, then you don't have any fibrosis, okay? So remember these two colors. So this first individual here, they had CAP score, steatosis score 204, so no steatosis, stiffness score 3.5, less than 7, so no fibrosis. This is a normal individual. This is actually my own FibroScan. No, I'm just kidding, probably. This person here has no steatosis, 209, so less than 220. But look at the fibrosis score, 33. So I said more than 7 indicates fibrosis, more than 15 indicates cirrhosis. Once you get to 25, it's portal hypertension. This is someone at risk for varices. So this is someone maybe with hepatitis C, so no steatosis, but a lot of fibrosis and cirrhosis. And finally, this individual here, they have a steatosis score 323, so this is severe steatosis, but the fibrosis score is less than 7. So this is maybe someone with NAFO, just fatty liver, but no fibrosis. So with a quick test, you can get two numbers, and you can actually tell your patient if they have advanced disease or not. And I like to use the steatosis score also when we try to do lifestyle modifications, because you can show them that they're losing fat from the liver. We have other technologies that can do the same thing. So this is the FibroScan. The same thing can be done with an MRI. It's called MR elastography, and it has an extra piece. So you put this drum-like thing on the liver, and this sends vibration waves, so you can look at the stiffness of the liver, and you can also determine steatosis with MRI. And then you can also add something called ARFI, acoustic radiation force impulse, to ultrasound machines, and this can also measure liver fibrosis. So the idea is that FibroScan is not unique, but the same concepts we apply to other technologies to get steatosis and fibrosis. And this way you can avoid doing a liver biopsy in many patients. All right, so these are the challenges that we face related to NAFLD and liver transplant. Number one is that NAFLD is becoming the most common indication for listing for liver transplant and for actually receiving a liver transplant. So NAFLD is very common, we know this. So if you take the general adult population, 1 in 3 people have NAFLD. So even in this room, some of us will have fatty liver disease. This is very common. If you look at obese individuals, it's about 50 to 70%. If you look at bariatric surgery population, 85%. And then patients with type 2 diabetes, up to 75% have NAFLD. So this is common. But keep in mind, we talked about the spectrum of the disease. So the majority of these people will have fat in the liver, but about 20-30% will have NASH, which is the aggressive form of the disease. Here you see the association between the prevalence of obesity and prevalence of NAFLD in different countries. And it starts in China, they have low prevalence of both. We get to the United States, and we are the champions for both obesity and NAFLD. So not a good situation. So when you have a common disease, you expect it to affect many people, and some of these individuals, again, will progress to NASH cirrhosis and advanced fibrosis. So this is data that we just published in the American Journal of Gastroenterology, but we wanted to look at the general American population and find out how many people have advanced fibrosis from this disease and how many people have NASH cirrhosis, okay? So most of the studies, I told you 20 to 30% will progress to NASH, and then maybe 10-20% have cirrhosis. This data was coming from referral centers. They do biopsies, and then they give you these percentages. But we wanted to look at the United States population. So we used a database called the National Health and Nutrition Examination Survey. This is a CDC project. Every 2 years, they have these cycles. They screen 30,000 individuals that represent the demographics of the United States. And they have data available publicly for anyone who's interested in research. You just need a good statistician. So to estimate the prevalence of fibrosis and cirrhosis, we used simple tests. So the first one is called AST to platelet ratio index, or APRI. So this looks at your AST and your platelets. Typically, when you advance with the disease, your AST goes up, your platelet count goes down. So this ratio actually increases when you have advanced fibrosis or cirrhosis. We use something also called the FIB4 calculator. So this has age, AST, platelets, and ALT. So you put all these variables, and then you get a number, and that can tell you if you have advanced fibrosis or cirrhosis. And then finally, we use something called the NAFLD fibrosis score. So this has even more variables that are associated with advanced disease. So higher age, higher BMI, having diabetes, having higher AST than ALT, low platelet count, and low albumin. So these are, readily available labs that everyone can do on their patients to see if they have advanced disease. This is how we define NASH cirrhosis. So cirrhosis was defined as having APRI, AST to platelet ratio index more than 2, and having abnormal liver test. And then NASH cirrhosis was defined as the presence of cirrhosis and obesity, diabetes, insulin resistance, metabolic syndrome, in the absence of hepatitis C, hepatitis B, or being on hepatotoxic medications. And this is how we defined advanced fibrosis. So if you had BMI more than 25, so overweight, elevated ALT, and then one of the following: APRI more than 1, FIB4 index more than 2.67, and NAFLD fibrosis score more than 0.67. Now, don't bother with these cutoffs, but this has been validated in multiple studies in different populations. So this is what we found. When we looked at advanced fibrosis, if you took a combination of the APRI, FIB4 index, and NAFLD fibrosis score, that from the 1990s to 2012, there was doubling of patients with advanced fibrosis in the United States. So now we estimate that probably 1.8 of the general population may have advanced fibrosis related to NAFLD. When we looked at NASH cirrhosis, we showed also doubling from 1999 to 2012, and you can see a sharp increase right here. So we extrapolated these percentages to the United States general population using the 2010 US Census data, and these are our estimates, that in the United States we have around 400,000 patients with NASH cirrhosis and about 4 million people with advanced fibrosis. So these are people that are likely to end up with liver cirrhosis, and many of them will need liver transplantation. So these are very, very high numbers that we are dealing with. And this is translating into getting more liver transplants for NASH. So this is an older study published in 2011 that looked at the UNOS database. You guys are all familiar with UNOS, but the different columns represent different years from 2001 all the way to 2009. And you can see the different indications for liver transplant. All of them are kind of stable, no change over the 10-year period. But when you look at NASH from 2001 to 2009, you can see astronomical increase. So NASH was deemed as the fastest rising indication for liver transplant in that study. What you don't see here is hepatitis C. I remember this is 2009, because back in 2009, hepatitis C was 40% of all the transplants. So this would not look this nice if we had hepatitis C here. So they excluded this. But actually, the picture is changing so rapidly now because we have very effective treatments for hepatitis C. So this is the most recent data, just published in 2017. And what you see here in the yellow line is NASH cirrhosis, and this is hepatitis C. So you can see how over the last 5 years, hepatitis C is coming down so quickly. And the first graph here is listing for liver transplant, and these are the actual numbers, these are the percentages. But the idea is that by 2015, NASH and hepatitis C are equal in terms of being indications for liver transplantation. And with the rate we're going with hepatitis C, I think by 2020, it's going to be very clear that NASH is the most common indication for listing for liver transplant. What you see here is actually receiving the liver transplantation, and again, you see similar story between NASH and hepatitis C. So hepatitis C is on the decline, and NASH is on the rise. So this is something that we will see more and more of, and as we cure all the hepatitis C patients, NAFLD is becoming the most common reason for hepatology visits in our clinics. The second challenge is that NAFLD is affecting people at a younger age, and many of them are progressing to cirrhosis in young adulthood. So we did a study to see how many young adults have NAFLD in the United States. So I showed you the data that 30% of the general population, 75% of the diabetics have NAFLD, but this is typically in patients in their 50s, 60s, older individuals. So we wanted to look at young adults, 18 to 35, and estimate the prevalence of NAFLD. We used the same database, the Enhanced database. This was the number of subjects we included, and we looked at 3 study periods, so 1988 to 94, 99 to 2004, and then 2005 to 2010. And we defined NAFLD as having overweight, BMI more than 25, and ALT over 30 for men and 19 for women. What we showed in this study that there was a sharp increase in the prevalence of NAFLD from 88 to 2010. And in 2010, we estimate that 25% of young adults, again, 18 to 35, have NAFLD. So this is 1 in 4 young adults, very common problem. And actually, when I was back in Cleveland, I followed a couple of young kids that had NASH cirrhosis or advanced fibrosis. So this is my most famous patient. She was featured in a story for Time magazine. You see all the snow in the background. This was February in Cleveland 3 years ago. But she developed NASH cirrhosis at the age of 12, okay? And we screened for everything you can think of to see why she progressed so fast. She was MZ for alpha-1 antitrypsin, so maybe that contributed, but otherwise we did everything you can think of, everything was negative. So she developed, again, NASH cirrhosis at the age of 12. And I look at kids here in San Antonio, and I know that many of them are walking around at least with advanced fibrosis and potentially cirrhosis. I mean, the severity of obesity we see here, and then many of them have every single component of metabolic syndrome, including type 2 diabetes, obstructive sleep apnea, dyslipidemia, so I'm sure that they have advanced disease. Now, in terms of natural history of pediatric NAFLD, we have way less data than adults, but this is one of the Largest studies that has the most longitudinal data from Mayo Clinic, they followed 66 children for up to 20 years. What they showed is that if you have NASH, you're more likely to die than the general pediatric population. And in that study, 2 patients developed NASH cirrhosis that needed liver transplant. One was at the age of 20, the other one at the age of 25. And the 20-year-old had recurrence of NASH after liver transplant, needing a second liver transplantation 5 years later, and then she died after the second liver transplant. So this is obviously not a good picture, even in children. But the issue is that, we've been hearing about liver transplantation done in pediatrics, but it's only sporadic case reports, so there wasn't much data. So to look at the real effect of pediatric NASH, we did this study, and we looked at all transplants done in the pediatric age group, but also in the young adult age group, and we stretched the age limit to 40. And the idea was that, if you get liver transplant at the age of 30, this is not an adult disease that developed when you're like 25. Probably you've had NASH since you're 5 or 6 years old and just progressed to NASH cirrhosis, needing transplant at the age of 30. So we looked at the UNOS database, and again, we looked at all liver transplants done for NASH cirrhosis before the age of 40. And we found 330 cases, including 14 children before the age of 18, and another 20 individuals before the age of 25. So the majority of patients, again, needed transplant between the age of 30 and 40, but still, we saw some children that needed transplant, some very young adults, and even if you get transplant at the age of 35, that's still super early, right? And this is really a metabolic disease that by weight loss, lifestyle, you can really slow it down, but just people have no clue that they have any issues with the liver until they have cirrhosis. We looked at all the indications for liver transplant in young adults and compared them to NASH to see the prevalence of NASH as an indication in this age group. So here you see autoimmune cholestatic liver disease. This is by far the most common indication for transplant in young adults. So they have PSC, autoimmune hepatitis, other rare genetic cholestatic diseases. And this has been stable over a 10-year period from 2002 to 2012. If you look at hepatitis C, it's on the decline. But when you look at NASH, it's going up. So even in young adults, back in 2002, it used to be about 0.5% of transplants we do. And for the last few years, it's been around 5% of transplants. So this is significant, and we're seeing this disease present at an earlier age. And when we looked at the outcomes for transplant for NAFLD, compared to other metabolic diseases like Wilson's disease or alpha-1, we showed that patient survival, there was a tendency to have lower survival, but for sure there was decrease in graft survival and increase in the need for retransplantation in patients that got the transplant for NASH cirrhosis compared to metabolic liver disease. All right, so I hope I convinced you that NASH can progress to cirrhosis, need liver transplant even at a younger age. The other challenge we are seeing now is that many of these people with NAFLD, they don't have cirrhosis, they don't have the end-stage liver disease, but they're showing up with cancer, hepatocellular carcinoma. So this is a study that my colleagues did back in Cleveland. They wanted first to look at patients with NASH cirrhosis. Okay, so if you have cirrhosis from NASH, what is the annual incidence of hepatocellular carcinoma? Now, we've known for years if you have hepatitis C cirrhosis, you develop hepatocellular carcinoma at a rate of 3 to 4% per year. So they had a nice cohort of 220 patients with NASH cirrhosis, compared them to patients with hep C cirrhosis. Here you see the rate in hep C cirrhosis, 4% per year, consistent with previous data. But when they looked at patients with NASH cirrhosis, it was 2.6% per year. So almost half of that of hep C, but still significant. And that's why ASLD, they recommend that if you have NASH cirrhosis, you start the screening with the ultrasound every 6 months and alpha-fetoprotein. But again, the main issue we're seeing now is that people are developing cancer even in the absence of cirrhosis. So this is data from the Veterans Administration database. They looked at 1,500 patients that presented with HCC over a 5-year period. You can see the mean age, 63 years. Vast majority were men, like any VA study. And then they determined their cirrhosis status, okay? So they looked at imaging and labs. And they showed that 80% had confirmed cirrhosis, but 13% had no cirrhosis. Then they looked at the underlying etiology of their HCC. So when they looked at patients with Hep C or Hep B, 90% of these patients had cirrhosis, then they developed HCC. Only about 7 to 9% had non-cirrhotic HCC. But when they looked at patients with NAFLD, about 1/3 developed HCC without having cirrhosis, okay? And this is really concerning because when you look at the number of people with NAFLD, we have, again, 30% of the general population. We estimate maybe 80 to 100 million people have this disease. So if you're going to start seeing cancer now in patients even without having cirrhosis, this is going to translate into a very high burden of HCC. In fact, here in South Texas, we have the highest rates of HCC in the nation now. This has been established. And it used to be more in states that have high prevalence of hepatitis B, but now NASH is really becoming the leading cause of HCC. So this is an area of interest of mine, and we're looking at data related to NASH and developing HCC, even if you don't have cirrhosis. What you see here is a nice study that looked at all the reports of HCC developing in people with NASH without cirrhosis. I don't expect you to see this, but this is a summary. So typically these patients present at an older age, so 60s to 70s. Typically they're more male than female. They have different fibrosis stages. So in some studies, some patients had zero fibrosis, no scarring, and still showed up with cancer. And typically they have multiple comorbidities, diabetes, obesity, dyslipidemia, metabolic syndrome. This was a study that we did at the Cleveland Clinic. We looked at HCC cases that came to us with an underlying etiology of NASH, and we divided them into cirrhotics and non-cirrhotics. And this was the non-cirrhotic cohort, so I'm just showing you here the fibrosis stage. So you can see that a good percentage of them had no fibrosis on liver biopsy. Some of them now had F3, so this is bridging fibrosis, pre-cirrhosis, so you can say maybe they had cirrhosis, but many of these patients had no scarring, still presented with HCC. So at this point, we estimate that the rate is very low, that it does not require you do the ultrasound for every patient with NAFLD because there would be so many people. So there's no screening guidelines for HCC in patients with NAFLD unless they have cirrhosis. But I know that people are looking at different criteria to see if we can find that patient who's at high risk that will warrant an ultrasound every 6 months. Could be a male patient starting at the age of 60 with diabetes, family history of liver cancer, but this criteria is being refined now. We'll skip this slide. Now this slide here was from a review chapter we did on the topic of HCC and NASH, showing you different mechanistic pathways that leads to development of HCC. But the key idea is that insulin is not good, and insulin could be carcinogenic. So if you have patients with type 2 diabetes, you know, the goal of life of most endocrinologists is to keep them away from insulin if possible. Sometimes you cannot, but insulin is not good, and there's data showing that there is association between insulin and potentially liver cancer. And this was a study that looked at a large database in Taiwan, looking at the effects of different diabetes medications on developing liver cancer. So what they showed is that if you use insulin sensitizers like pioglitazone, rosiglitazone, there was decreased risk of cancer. Same thing if you use metformin, which is an insulin sensitizer. But if you use insulin, there was increased risk of liver cancer, okay? So again, anything you can do to increase the response to insulin, use insulin sensitizer, it's been shown to decrease the risk of cancer. If you give insulin or if you give medications that lead to the release of insulin, like sulfonylurea, you can increase the risk of liver cancer. So we know that metformin is not a good drug for fatty liver disease in terms of improving liver fibrosis, but I like to use it because of this potential effect of decreasing liver cancer. All right, so the last challenge I'm going to talk about is that even if you get a liver transplant for NAFLD, you can have recurrence of disease, and then you can deal with similar issues after liver transplant. So for years we thought, oh, you get your liver transplant for NASH, you're okay, you're not going to die from liver disease, most likely you'll die from heart disease or cancer like everyone else. But this is a nice study that was just recently published. They looked at 103 patients that had liver transplant for NASH and had long-term follow-up, okay? So they followed them on average for 10 years. And then what they did is they did the FibroScan. So this is transient elastography, fibrosis score with CAP, steatosis, or they did a liver biopsy. So this way you can see how many patients developed recurrence of fatty liver after liver transplant and how many of them had advanced fibrosis or cirrhosis. You can see the mean age here was around 56 years and mean BMI at 31. So these are the main findings. I apologize, this was in press, so this is what you see here. I couldn't find the final publication, but what they showed is that the majority of people had recurrence of fatty liver disease in the form of NAFLD. About 50% had just steatosis, but about 45% had NASH, okay? So again, the majority of people will have fat reaccumulate in the transplanted liver. But the main finding of this study is right here. So this is F3, bridging fibrosis. This is cirrhosis. And what they showed that about 25 to 30% of these patients will have either advanced fibrosis or cirrhosis in the transplanted liver based on liver biopsy or FibroScan. So this is very important. I think the reason we were biased in the future was that patients with NAFLD got transplanted at an older age, so they're 60, 65 when they got the transplant. They had so many comorbidities at baseline, heart disease, diabetes, whatever, and then they died within a few years from transplant from something not related to liver disease. So people felt reassured that, okay, you're not going to develop recurrence of NASH and need another transplant for this indication. What this data shows you is that even after transplant, if you're young enough and healthy enough and you live 10, 15, 20 years, that you are likely to develop significant recurrence of the disease. And some of these patients may need transplantation for recurrent NASH and liver graft. So I think this is a very important study. And I showed you data that this disease is affecting younger and younger patients. So as we transplant people at a younger age, we have to be vigilant about modifying their lifestyle and screening for recurrence of disease. All right, so in this study, 32 patients died. You can see the leading cause of death. So again, this is, I think, the reason why we were kind of biased in the past, because most people die from cancer, infections, cardiovascular disease, but 9% of the death was attributed to graft cirrhosis. All right, so moving on to the management of NAFLD. I know I painted a very grim and sad picture, but actually we can do things for these patients before they need liver transplantation. The mainstay of treatment today is weight loss, and we know that if you lose about 10% of your body weight, you can actually lead to resolution of NASH and fibrosis in about 45%. So this is really much easier for patients when you say you need to lose 10% of your body weight than if someone says, oh, you need to lose weight and go back to being normal weight, which is almost impossible. So this translates, if you're 300 pounds at baseline, the goal is 30 pounds, which is 10% of your body weight. Okay, if you're 250 pounds, then the goal is 25 pounds. And this is what we use in our clinics. Problem is, it's easier said than done. So this is intense research I've been doing since I moved to San Antonio, Texas, at all the food challenges in the city of San Antonio. So here are some of them. I introduced to you the 52-inch pizza. Do you guys know where you can get this? Yes, okay. Let's not say the name, but I show you the 3.5-pound cinnamon roll, 3.5-pound burger, the taco challenge, the cheesesteak challenge, and the ramen noodle challenge. And this is, I think, 3 pounds also. So this is real, okay? This is all in San Antonio. But this wins the cake. So this is the largest burger in Texas, 27 pounds. And this is in Houston, I think. This is all, again, available on Google if you're interested. But it's really, I mean, in Texas, there's this mentality that everything is bigger and they say better, but I think it's bigger and way worse than anywhere else. This is not good. So we need to change our attitude toward food and hopefully stop these food challenges. Now, I talked about weight loss, and I want you to know that bariatric surgery is by far the most effective way for weight loss. And actually, it works really good for patients with NASH and fibrosis. So this is a French study published a couple of years ago now. They took 109 patients that were undergoing bariatric surgery that had biopsy-proven NASH. And they did a biopsy at the time of surgery, and then 1 year later, you can see the type of surgery here. They do the gastric band in France. We rarely do it here in the United States. But BMI actually improved quickly within 1 year from 49 to 37. So this cohort lost a lot of weight. And this is what happens when you lose weight. So remember, everyone had NASH at baseline. In 1 year, 85% had resolution of NASH, okay? So this is the aggressive form of the disease. It doesn't mean that they had no fat in the liver, but it means that, you know, if you have resolution of NASH, you don't have significant inflammation, no liver injury, and no significant fibrosis. So very effective. And then here you see the fibrosis stage. So this is no fibrosis, stage 1, 2, 3, 4, which is cirrhosis. This is at baseline. This is 1 year later. So you can see that the percentage of patients with no fibrosis increased, and then there was some regression in patients with advanced fibrosis after 1 year of treatment. So bariatric surgery is very effective. I think it's the most effective treatment we have today for this disease, but we know that in real life, only 1 to 2% of people that qualify for bariatric surgery end up getting the surgery. So we have new drugs, okay, that we are working on, and I think these will be available by 2019. So what I'm showing you here is all the medications that are in phase 3 clinical trials, okay? And to understand the mechanisms, you have to understand disease progression in NAFLD. So everything starts with insulin resistance, leading to what we call de novo lipogenesis, which is making new lipids that go inside the hepatocytes, or release of free fatty acids from adipose tissue that can go into the liver. This leads to hepatic steatosis, creates a state of metabolic stress and alterations in bile acid signaling. This leads to hepatocyte injury, inflammation, and eventually liver cell death or apoptosis, leading to the activation of what we call the hepatic stellate cells and fibrosis. So each of these steps can be targeted. The first drug I have here is called elafibranor, which is a PPAR alpha and delta agonist. You guys are probably familiar with PPAR gamma agonists. These are the glitazone medications, diabetes medications. So this works on PPAR alpha and delta, very important for fatty acid metabolism and lipid metabolism. So this can target the first step right here. The drug, again, is called elafibranor, and the phase 3 study is called the Resolve It trial that will look at the effects of this drug for patients with NASH. The second drug is called obeticholic acid. This is actually available on the market today for the indication of primary biliary cholangitis, or PBC. This is what we call an FXR agonist. FXR is the nuclear sensor of bile acids, but it has very important metabolic effects and fibrogenic effects. And the phase 3 study looking at it is called the Regenerate study. Sinacrivaroc is what we call a chemokine receptor inhibitor, and these are the ones that it works on, chemokine receptor 2 and 5. So this decreases liver inflammation and fibrosis. We have the Stellaris study looking at it. And the last medication is called selonsertib. This is an apoptosis signal regulating kinase or ASK1 inhibitor. And the studies looking at it are the Stellar 3 and 4. So I'm going to show you some efficacy data for these drugs. Don't memorize these names. Probably only half of them will make it to the market. I'll bother with knowing this data, but just know that we have drugs coming, okay? So just be excited like me. So this is the first drug is elafibranor. This is the PPAR alpha delta agonist. This is a phase 2 study called the Golden study. They included 274 patients with NASH. NAFLD activity score was 3 or more, so this is considered mild disease and any stage fibrosis. And then they classified the patients into severe NASH based on this NAFLD activity score from 6 to 8, moderate NASH from 4 to 5, and mild NASH a score of 3. What they showed with this drug that if you use this dose, 120 milligrams daily, if you had severe disease or moderate disease, there was significant improvement compared to placebo. Unfortunately, if you have mild disease, the placebo response rate was high, and that skewed the primary outcome of the study. So they moved this drug to phase 3 now. And again, we have the Resolve It trial looking at this drug, and they're only going to look at moderate to severe disease with this medication. The second drug is obeticholic acid. They looked at it in the Flint trial, 72 weeks of 25 milligrams of obeticholic acid versus placebo. They included patients with more severe disease based on this NAFLD activity score. And they showed that in terms of improvement in this NAFLD activity score, being on the Ocaliva or obeticholic acid was more effective than placebo. And what was impressive was that also 35% had improvement in liver fibrosis by one stage or more. And this is only in 72 weeks. So we're excited for this medication, but it has side effects, including itching and increase in LDL, and that may actually decrease the excitement for using it in patients with NASH. Sinecrivaroc is the anti-inflammation, anti-chemokine receptor medication. They looked at it in a smaller study, comparing this drug to placebo, and they thought it's going to help with NASH and improving the severity in terms of NAFLD activity score, but there was no effect whatsoever. But they found actually significant improvement in fibrosis. This was 20% compared to 10% with the placebo arm. And that's why they decided to use this drug as an anti-fibrotic now. So we have the Stellaris study looking at this drug in patients with significant fibrosis and NAFLD as the underlying etiology. And then the last drug is selonsertib. This was a quick study, 24 weeks. This is the apoptosis signal regulating kinase inhibitor. I don't want to get into details with this study because there was another drug that they looked at as an anti-fibrotic that did not do anything, so they considered it as the placebo. But I just wanted to pay attention here. So if you use the high dose of this medication, selonsertib, compared to placebo, there was significant improvement in fibrosis. So this is another drug that we hope we can use in patients with advanced fibrosis, even NASH cirrhosis. And finally, I'm going to leave you with this clinical trial that we just presented from the Texas Liver Institute at the last European Liver Meeting in Amsterdam. This is looking at a new target. It's called ACC inhibitor. So ACC is acetyl-CoA carboxylase enzyme. It's a very important enzyme in converting acetyl-CoA into malonyl-CoA, which is very important in de novo lipogenesis, so making new lipids in the liver, but also it decreases fatty acid oxidation. So this is one way we get rid of extra lipids, is we use fatty acids to be oxidized as a source of energy. So this enzyme and this compound are bad because they make you make more fat and they make you use less fatty acids. So the drug is called GS0976. It doesn't have a name yet. GS stands for Gilead Sciences, and they're looking at it as an inhibitor of this enzyme to basically decrease de novo lipogenesis and increase the utilization of fatty acids. So this is the rationale for the study. They wanted to look at it compared to placebo. This is the study design. So it was a quick 12-week study, and the primary outcome was not based on liver biopsy. It was based on MRI data. So we did this MRI, proton density fat fraction, or PDFF. This can quantify how much fat you have in the liver. We did it at baseline, at 4 weeks, and then at 12 weeks. And then we did MR elastography. This can tell you how much scarring you have in the liver. And then we did some experiments to check de novo lipogenesis, but this is not relevant to liver disease. This is how we defined inclusion criteria. You needed to have more than 10% fat based on this MR PDFF, and then a stiffness of more than 2.88, indicating significant fibrosis. And this is the primary outcome of the study. So when you look at steatosis based on the MR PDFF, this is baseline, this is week 12. You can see significant decrease, and this is only 3 months of using this drug, and this is regardless of weight loss. So there was 43% decrease in liver fat using this drug for only 12 weeks. So this is really remarkable. Again, these patients did not lose significant weight. And then when we looked at the individual patients right here, you can see how almost every single one had significant decrease in their liver fat. When we looked at an outcome of 30% reduction of fat at week 12, 70% of the subjects met the primary, met this secondary outcome. So this is, again, pilot data, just looking at here liver fats. We're looking at fibrosis also, but this is exciting. In terms of other biomarkers of liver injury, ALT and AST, you can see significant decrease by week 12. Gamma GT is an inducible enzyme, so initially it went up, but by the end of the study it came down. Cytokeratin 18, this looks at hepatocyte cell death. So basically, this is apoptosis, this is necrosis, and you can see a decrease. And then TIMP1 is a biomarker of liver fibrosis, and this also decreased with only 12 weeks. So this is very encouraging that potentially you are affecting liver fibrosis with only 12 weeks of therapy. So again, lifestyle is great. Lifestyle works. If you can lose weight, good for you. But you have to think about this disease as something that's progressive. Most people are not successful with lifestyle. Only about 5 to 10% of people can achieve that 10% goal for weight loss. So we need drugs, and these are very promising targets. So this is the slide before last, but I just want you to think about the management of NAFLD the same way today we think about the management of diabetes. So I told you that this NAFLD, steatosis part, is less progressive, and probably these people will not die from liver cirrhosis, but this is really a risk factor for progressing to NASH and advanced fibrosis. So this is similar to prediabetes. Prediabetes, insulin resistance, this is not a disease. It's really a risk factor for progressing to diabetes. So what do we do for prediabetes? We recommend weight loss and exercise, and sometimes we add metformin. I think we should do the same for these patients with steatosis. They need to lose weight, exercise, and we can manage their comorbidities. So their prediabetes or diabetes, their hypertension, their dyslipidemia, their obstructive sleep apnea, and I think this will help even with the fatty liver disease. But when you have NASH, I want you to think of NASH as the aggressive form of NAFLD, the same way we think about type 2 diabetes. So when you have type 2 diabetes, I mean, everyone will tell you need to lose weight, you need to exercise, but no one is waiting on your weight loss before they start you on diabetes medications. If you have bad diabetes, we're getting you on medications from day one, and some guidelines now recommend that depending on the hemoglobin A1C value at presentation, you start 2 medications from day one. And then if you don't get good response in 3 months, you add a 3rd medication, okay? So when you have diabetes, this is the disease that needs treatment. Lifestyle is great, but we need medications. And same thing with NASH. But in diabetes, we have a bunch of classes you can choose from. You can do GLP-1, SGL2, T2. In NASH, we don't have anything really yet, but we have a bunch of drugs coming, and I showed you data on obeticholic acid, elafibranor. Some people today use vitamin E and pioglitazone, but they do have also issues with potential side effects, so we're waiting on new drugs. And then when you have advanced fibrosis cirrhosis, I want you to think about it as diabetes complications. So, someone with end-stage renal disease from diabetes, retinopathy. So sometimes these patients, you can try maybe to salvage them with insulin, being aggressive with diabetes medications, but sometimes you need your kidney transplant. And same thing with advanced fibrosis leading to cirrhosis and stage liver disease. You can try with antifibrotics, but sometimes you're going to need liver transplantation. And the key also in this is that this is not going to be a hepatitis C story, okay? Hepatitis C, within the last 5 years, we went from curing 30-40% to 99%, and now hepatitis C is going to become a rare disease probably in 15-20 years. NASH is going to be like diabetes. We've been tackling diabetes for the last, I don't know how many years. We have many drugs. We use combination drugs, and I don't see diabetes going away anytime soon. So, be prepared that these patients will be on potentially multiple drugs for this disease. And despite that, we still have patients with diabetes progressing to end-stage organ damage, and same thing will happen with NASH. All right, so take-home message is NAFLD is very common. It's a potentially serious liver disease, especially in patients with NASH, advanced fibrosis, and now we are seeing young patients presenting with cirrhosis from this disease. NAFLD is or has become the most common indication for liver transplantation in the United States. Screening for NAFLD should be considered. I think now we have this FibroScan machine. We have other technologies to screen for it. You can find who has advanced disease and who doesn't. So I think we need to change our guidelines. I know ASLD, they're working on new guidelines that should be released by the end of this year or next year. EASL, the European Society for Liver Disease, they actually recommend you screen for NAFLD in patients with metabolic syndrome and type 2 diabetes. And finally, NASH-specific therapies are coming soon, so hopefully this will change the attitude toward this disease once you know that you have effective drugs that you can use in addition to lifestyle. And with this, I will conclude. Thank you so much for your attention.